Our brief today is to look at serial lesion evaluation with physiology, a case-based introduction, and it's my pleasant job to introduce the topic. Location of a disease in patients with angina is often a diagnostic challenge, and the location of the disease could be epicardial or microvascular. Angiography can sometimes be misleading, and the angiogram may overestimate or underestimate lesion severity, as was shown in the sub-study of the FAME, with a very, very large percentage being both misclassified both as not stenotic enough or too stenotic. The true definition of fractional flow reserve that has emerged as the gatekeeper for the performance of the angiogram is the maximum achievable blood flow in a stenotic artery divided by the maximum flow in the same artery without stenosis. And this is something that we all know and we all are familiar with. Now, FFR incorporates lesion severity, myocardial territory and viability, as well as collateral perfusion into the calculations that are inherent. Serial stenosis is one of the unmet needs of this particular physiological technique. Now, whenever we have a stenosis severity at rest, there's absolutely no change in the flow. But when there is a requirement of hyperemia, you can see that there is significant decline in the amount of hyperemic flow that can be augmented in a lesion with significant stenosis. Now, this is complicated when there is more than one lesion. By definition, more than one lesion means two lesions that are separated by at least 20 millimeters or 10 millimeters, depending on what stent length you're going to use. Basically, the decision whether to use a single stent or two. There is also complex interaction between the two stenoses, which are in series, with the proximal stenosis leading to an overestimate of the distal stenosis and the distal stenosis leading to an underestimate of the proximal stenosis. And this is the knotty problem that we're going to solve over the next hour or so. Thus, this, as I said, is defined by lesions requiring at least two drug-eluting stents, which can be divided by a normal-looking area, and we have to decide whether to use one or to two, stent both, stent just one, or otherwise. There have been multiple simulations of these tandem lesions, and we're going to look at all this theory. The points for discussion today are: how do we assess the significance of serial or tandem lesions when we're looking at significant coronary artery disease and chronic stable angina? Can we use existing physiology markers to help? And what's the evidence? This is going to be a case-based approach, and I'm going to invite Dr. Ajay, whom we all know, to introduce the case, and then we'll see what to do about it.